I am going live on YouTube. So I'm just working towards that. Okay, everyone's joining in. We're going to start in just about a minute. We had 186 people registered for today's general meeting. So, and I can see the participants are still coming in. Okay, let's get started. All right, it's 7 p.m. So good evening, everyone, and thank you for joining us tonight. My name is Rovina Nimbalkar, and I am the Executive Director at NAMI Santa Clara County. Before we begin with our general meeting tonight, I'm going to go over some updates at NAMI Santa Clara County. Our helpline is up and running from 10 a.m. to 6 p.m. Monday through Friday via phone as well as email. Our after-hour family support is still available on evenings and weekends. Our support groups are all listed on our website and offered over Zoom. Our website is www.namisantaclara.org. All of our education classes, such as family to family, familiar to familiar, persona to persona, peer to peer, provider education. For these, to get more information, you can contact our helpline number, which is 408-453-0400, and select option 1 to get further details and to get on the interest list. NAMI Basics is on demand and on our website, and you can take it at your own pace, and so is NAMI Homefront. Our community peer program continues to match via hospitals and self-referrals. Our FaithNet 101 is going to be on May 20th, I believe, but you can call our helpline to get more information about the FaithNet 101, the Mental Health 101, sorry. Okay, so NAMI Walks Silicon Valley is going to be on October 7th at the History Park. We're really excited about going again in person after the pandemic for the second year. So I hope you can all join us. And to register for NAMI Walks, our website is namiwalks.org/Silicon Valley. And our NAMI Walks kickoff picnic event, I know that we had mentioned in the newsletter that it's going to take place on July 22nd. However, there has been an issue with the location. So we are going to send out an email soon. We're working really hard to find another location for the kickoff event, which is supposed to be July 22nd, and keep you posted on that and send you an invite as well. So keep a lookout for your email. Okay, so now that I am done with giving you all the updates, let's get to the general meeting. So today we have Dr. Po Wong, who will be speaking on bipolar disorders at our general meeting. Dr. Wong will cover the course of illness for bipolar disorders, emphasizing the depressive component, and will discuss the newest medication options and how they differ from earlier treatment options. Bipolar disorder treatments has come a long way since the discovery of lithium in 1949. Treatment options and outcomes for bipolar disorders were limited and similar to schizophrenia prior to 1990s, decade of the brain. Surprisingly, a typical antipsychotic medication that were developed primarily for schizophrenia treatment turned to have important effects of bipolar disorders, including benefits of mania, mixed and depressive episodes. Although mania is the characteristic feature of bipolar disorder and is depressive episode that causes the most chronically disability. Dr. Wong has expertise in the biology and treatment of bipolar and depressive disorders. Dr. Wong graduated from Washington University School of Medicine, St. Louis, and then attended Stanford Psychiatric Residency, where he also served as a chief resident, then National Institute of Mental Health, T32 Fellow in Bipolar Disorders Research. After completing training, Dr. Wong joined the faculty of Stanford. Dr. Ketter and Dr. Wong collaborated on establishing the Stanford Bipolar Disorder Clinic, and Dr. Wong continues on academic practice at Stanford. I'm going to hand it over to Dr. Wong now, and I do want to let you know that this is a webinar feature. So we have a Q&A section that you can see, so you can post your questions there. And then we have the chat section. I hope that the chat is allowing everyone to chat. If not, I am going to just activate that. Okay, here we go. I think everyone can chat, as you can post in chat. So I would recommend keeping the chat only for comments, and keeping the Q&A section, posting your Q&A in the Q&A section. That way I can get easy access to it and I can ask towards the end of the presentation. And so I'm going to hand it over to Dr. Wong now, and do want to let you know that this meeting is being live streamed on YouTube. And so if you want to go later on and view it, you can do that. Okay, over to you, Dr. Wong.
Thank you very much, Ravina. So this is the first time I've done a YouTube thing, so bear with me. So as Ravina expressed, I work at Stanford, and I've been doing bipolar research and treatment for many years now. I'm going to share my slides. I have very few slides today because I know that there's a lot of Q&A. So let me pull that up for a second here. So I think everybody can see that. So I'm going to cover the current state of treatment for bipolar disorders, and purposely made the slides shorter today because when I've done these kind of talks, the community, there tends to be a lot of other kind of questions other than the presentation. So I want to leave that available for today. Bipolar disorders is really manifested by and defined by the manias. So the manic episodes is what defines bipolar disorder as different from schizophrenia, from depression, but really what it is for bipolar disorders is that it's, let me get to one second. Let me advance my slides here. There we go. Really, the issue of bipolar disorders is not so much the mania. In this slide here, let me orient everybody. This slide here is a course of illness of 82 composite patients with bipolar disorders, where on the x-axis, you have the age of the patient. So from age 20 all the way to 40-something, these are the patients they followed in this time. And the red bars are periods of mania, and the yellow bars are periods of depression. Okay. So what we see is that even though bipolar disorders is manifested by the manic episodes, and you see plenty of manias in these patients here, it's really the depressions that are very prominent, and it's also the ups and downs, the cyclicity, instability of mood that's the most prominent. So really that's the focus of treatment of bipolar disorders is not just the mania, it's really the depressions and then the mood instability as well. In fact, if you look at patients with bipolar disorders, this is a big study that happened in the early 2000s. And again, I'll orient patients, everybody to this slide. These are 146 patients with bipolar 1 and 86 patients with bipolar 2, followed for an average of about 13 years. And they looked at these patients' mood state during this time. So even though mania is defined as bipolar disorders, you can see that the red bars of the pie actually kind of small. So 9% in the bipolar 1s and 1% in bipolar 2s. But it's actually the blue section, which is the depression, as a bigger component for these patients. So in bipolar 1 and bipolar 2, the depression is a bigger component. So even mania is the defining feature. It's actually more commonly depression that's the presenting feature of these patients. In fact, if you look at bipolar 2 patients, they're often often depressed than anything else. So even their period of depression, which is 50% of the time, is more than the time when they're doing well, which is the gray section of the 46%. And in the bipolar 1 patients, about a third of the time they have depression versus a little bit more than half where they do okay. So it's really the depression that we're trying to address, even though the mania is something that really defines it. As a general story point here, This is a diagram of the major class of medications that we use in bipolar disorders. It's a discussion point that we can have later on. You can think of medications in individual fashion, and each of these have different benefits and side effects that we can talk about, but it's easier to think about in terms of classes because there's some similarities. So lithium by itself is a class by itself. It was discovered in 1949 by an Australian scientist and has been the mainstay of treatment for bipolar since then. Then there's a class of medications called the anticonvulsants. Anticonvulsants were developed in the late 60s, early 70s, mainly because at the time, researchers in bipolar disorders thought that bipolar disorder was a mood seizure. So it was patients that were having both manic episodes and depressive episodes. So they thought that antidepressants, excuse me. Let me drink some water first. And
Are you okay, Dr. Wong?
yeah, I just need to drink some water. Just 1 second.
Yeah, sure.
So they thought that because they were mood seizures, that the anticonvulsants would be an effective treatment for this type of patient. And they were lucky because the first treatments were Depakote or valproic acid and carbamazepine. And those two medications actually turned out to be effective for bipolar patients. Subsequent medications they looked at weren't as effective. So it turns out that this class of medications is not universally effective for bipolar disorder, but some of the early ones like valproate, carbamazepine, lamotrigine are effective for bipolar. During that phase of anticonvulsant research, it actually turned out that this other class of medications, the antipsychotics, turned out to be quite effective for bipolar disorder. Some of these medications included Zyprexa, Seroquel, Abilify. You can see the rest of the list. These are the mainstays of treatment right now, mainly because of their rapid onset of action, their utility for mania, for mood stability and mood cycling, as well as the depression. So we'll cover all these things down the road in this presentation. It turns out that there's another class of medications, antidepressants, and you would assume that this class of medications would be very effective for bipolar illness because depression is a big part of illness. But the antidepressants actually have a more minor role in bipolar disorders treatment. I'll talk about that as well. In terms of other medications, there's a whole bunch of other treatments as well. There's benzodiazepines, atypical antipsychotics. There's other agents that don't fit in these other categories that we have. There's ECT, electroconvulsive therapy, we can talk about at times. And there's this new treatment called transcranial magnetic stimulation. Okay. So these are all effective agents that can think about for certain patients, certain people with bipolar illness. Now, when you look at patients in the community, what are the most common medications that are used? It turns out because depression is the most common feature of bipolar, antidepressants are the most common treatment medication. Now, in the prior slide, if people will have noticed, I said that antidepressants have a more minor role. And that's because in the community, they haven't really caught up with all the research, right? And we'll talk about that in a little bit. So antidepressants are used because when patients get depressed, they think they should treat the depression. And the number one treatment for depression is antidepressants. Other agents are less commonly used. And in fact, lithium, which was the first agent used, you can see it actually has a smaller percentage of use, mainly because of side effect benefits and also because of novelty. As new things come out, people want to try the new things. Okay. If you look at bipolar specialty clinics, so places like my clinic at Stanford, where we study bipolar illness, you'll see that actually mood stabilizers and convulsants like VPA is Depakote, CBD is carbamazepine, lithium is LI, and the new antipsychotics, they have a bigger role in the treatment of bipolar illness, and the antidepressants becomes a smaller component. The reason we do that is because we notice two things. One is that these medications that I've noticed here have a more data or literature studies showing that they're beneficial for bipolar illness, including the depression. And antidepressants, actually, even though they're effective for depression, they may not work quite as well in bipolar types of depression. So that's one thing that's different between what I mentioned before, where mania differentiates bipolar from the other types of psychiatric illnesses. Even the depression in bipolar is not the same as the depression in unipolar depression or schizophrenia or something else. So maybe the depression in bipolar depression is different from other types, and maybe the treatments are different as well. So how can we sort of move forward understanding that bipolar disorder, even though mania is the main issue, depression is much more common. So we see a lot of depression. And then that first slide I show you is that there's a lot of cyclicity, a lot of episodes, right? So there's different ideas or strategies for treating bipolar illness. Number one strategy, which is the most common, is that when people are manic, they treat the mania. And when they're depressed, you treat their depression. So that leads us to treat patients more with antidepressants, because when they're depressed, you use an antidepressant. And when they're manic, you give them lithium or antipsychotic or Depakote or anticonvulsant. So that's the typical way most psychiatrists in the United States, in the world, treat bipolar. They treat whatever they see in front of them at the moment, depression or mania. In fact, if somebody comes in and they have a mixed episode, so they come in with mixed symptoms, meaning that they have some mania and they have some depression. That's what a mixed episode is. Most often, the depression in those times is the most prominent feature. They may have mixed symptoms, but the racing thoughts, the high energy, those things don't seem to be as problematic for people as the depressive symptoms. And so when that happens in a mixed episode, the depression is oftentimes the treatment target. Even though in a mixed episode, antidepressants can make the situation worse, where the mood stabilizers can make the situation much more stable. So that strategy of separating treatment of mania and separating treatment of depression is a common strategy, but it's not the most effective. The next strategy is to treat bipolar illness, like the first slide I showed you, with a lot of mood episodes. And the goal would be to try to stabilize the mood episodes. So the goal of bipolar treatment, even if you see mania is one episode, depression was one episode, and you're trying to decrease the number of episodes. And the polarity, whether it's elevated or depressed, is not so relevant, but just trying to stabilize. Okay. So that's one strategy. And that strategy would be to mainly stabilize. And if patients get particularly depressed and they're stable, then you can treat for the depression. So that typical treatment would be like lithium, stabilizing the mood, even if they're stably depressed, and then add an antidepressant on top of that. That was the next research-based type strategy, thinking that bipolar illness is not really mania and depression. It's the cyclicity, it's the movement between mania and depression. So therefore, you have to stabilize first. The most current strategy for treating bipolar is to look at treating mood stabilization, but thinking about both the mania and the depression. Now, the reason that's different from the second phase is because some medications are better for treating mania, and some medications, fewer, are better for treating the bipolar depression. So therefore, if somebody comes in and has more mania, one might choose something that is a stabilizer, but helps better for the mania, but doesn't particularly worsen the depression. So something like that might be something like Depakote. Depakote is very good for mania, but it's modestly effective for depression, bipolar depression. From this point forward, I'm going to try to say, when I say depression, I mean bipolar depression, but I'll try to keep it intact with myself. So when somebody is coming in and they have bipolar and they are manic, then you might use Depakote because that will treat the mania. And then following the mania, the person might become depressed, and the Depakote may help prevent that or might treat it and minimize it. Lithium does the same thing. It helps with mania more. The reason this mood stabilization plays a role is because some medications may have a better role in the depression. So lamotrigine, for instance, is a medication that helps better for stabilizing mood, but better in the depression. Okay. So when people come in with bipolar and they're manic, you may not try Lamictal. But if you come in bipolar and they're depressed, you're trying to use the lamotrigine to make them more stable, but from the depression standpoint. Okay. And hopefully, as more medications come around, we may have medications that they have benefits in the mania and benefits in the depression. So they sort of stabilize from above and below. Okay. I will step back and say one thing. When I say stabilize, I don't mean flat mind, like no emotions. I don't mean that. That's a side effect. We don't want that. I'm talking about stabilize, meaning like not too high and not too low. And so you sort of have mood in a range, like everybody does. Everybody has emotions and mood in a range. And that's what I mean by stabilize. So our current strategy is developing from treating the mania for itself, treating the depression for itself, and getting suboptimal results because you're going back and forth, versus now we're trying to stabilize the whole picture. And that's why I showed you the first slide, which is that when you look at patients who have suffered from bipolar illness, it's not that they're depressed, it's not that they're manic. We worry about that, of course. It's that the whole picture of the person and their social environment and their anxiety, all that put together, and we're trying to really stabilize their entire life as much functional as possible. So this is the last slide I have, and it's a doozy slide because it covers everything. And then I think as we move along, I'll have a lot more to say about the questions. So this is a list of just the FDA-approved medications in bipolar disorder. There's a whole bunch of other medications I'm open to talk about, and treatments I can talk about, but these are the FDA-approved agents. Now, what does it mean to be FDA-approved? That basically means that you have to have at least 2 FDA-approved, which are double-blind, placebo-controlled, sort of gold standard studies. These are the most robust studies. And if you have a question about that, I can tell you what that means for that most robust. So these medications here, except for lithium, and I'll explain why that is, have the most robust studies showing that these are beneficial. Okay, that doesn't mean other things don't work, but this is the strongest evidence. The reason lithium doesn't fit that category is because it's from the 1970s, and so it actually had been grandfathered into the bipolar FDA indications. Okay, but it's still effective. So if you look at these 3 columns, the things that are approved from the FDA for acute mania are quite extensive. So there's a lot of medications approved for that. And the most recent one is cariprazine or Vraylar in 2015. Okay. Even though I said mania is the defining thing, depression is the main feature. And so you see what you have in acute bipolar depression. There's 1, 2, 3, 4, 5 things approved for bipolar depression. Okay. So much fewer. So even though depression is a bigger component of the illness, we have fewer things FDA available. There's a few reasons for that. One reason is that for many years, we just thought mania defined bipolar. Research did as well. So there was an emphasis on the depression. And secondly, manias tend to respond better to medications because it's much more acute. It's a higher severity. And so that you have more room to come down and improve, right? Depressions can be pretty severe, of course, but they tend to be longer, more chronic sometimes. And then when people have more chronic symptoms, sometimes it takes a little bit longer to get better. And so those studies tend to be longer and more expensive to do. So pharmaceutical companies don't particularly like to invest in that as much. But in the last few years, because we have so many acute mania drugs, then they've been spending more time looking at these acute depression drugs, which is really helpful for us. So we're not just sort of shooting in the dark, trying to find a good solution. The last column, longer-term treatments. It used to be thought this was a good, useful column, meaning that what would you put somebody on to keep their mood stable? But it turns out most of these medications aren't longer-term treatment agents. What they are is that they are patients that got better on this medication, and then you continue them on medication for about a year. And if they stay better, then that is getting on this list, this long-term treatment. What that means is that it's not that these medications work in the long run. It's that if you take this medication, you get better acutely in the short run, then if you stay on it, then that's a good point to stay on it. And that's kind of a obvious point, because if you do well on one medication, there's not a good reason to switch to something else because you already know that you do well on it. Okay. There's a whole list of medications here. We can talk about all of them. I'm sure questions will lead to all those things. And so I'm going to, even though this is pretty short, I'm going to open it up to questions that may be available. This is a Stanford, everybody knows that from the front. See me okay?
Yeah, I think you're sharing your screen right now.
Oh, let me get rid of that, sorry.
Your email is being shared too.
I have to try to figure that out, I'm sorry.
Yeah.
Okay, let's see here. Here it is.
Yeah, perfect.
Okay.
Thank you so much for the presentation. I really appreciate it. So what I'm going to do is I'll start asking questions. So the first question is it common for patients to be more accepting and aware of their depressive episode symptoms compared to manic episodes?
That's a really good point. So yes, that's true. So patients and people, when they're depressed, they recognize they're depressed. They don't want to be depressed. When people are manic, it kind of feels good. And so they oftentimes don't recognize it or don't appreciate it or don't see the damage it causes. So that's true.
Yeah, thank you. Okay, somebody's asking, will there be a YouTube link of this recording be available? My son has bipolar disorder, and I think he could really benefit from watching this. Yes, I will share it in the chat right after. So I'll do that. Okay, so let's see. The next question is, Dr. Wong, do you see patients who are on Medi-Cal? If not, what is your contact information for consultation?
So look, why don't we not share the information? We can look at NAMI's website for some of that, for that contact information. But at Stanford, we don't take Medi-Cal. In the clinic, we take Medi-Cal when people are hospitalized, but not in the clinic. It's just a contracting issue.
Okay. I'm just sharing the YouTube link with everyone.
Okay, great.
So they can have that. Okay, there's more question. Dr. Wong, can you elaborate on the use of Ativan?
Say the drug.
Can you elaborate the use of Ativan? Maybe I'm pronouncing it.
Oh, Ativan, yes.
Yeah.
So Ativan is a very commonly used medication. It's a benzodiazepine. It's an anxiety medication, super commonly used. It's frequently used in bipolar and depression across the board for psychiatric illnesses because it helps for anxiety. And pretty much everybody has anxiety of some degree. And when people are under stress, like they're depressed or they're manic, then their anxiety is worse. So that's why Ativan has such a high use. It also works very fast and it wears off quickly. So it doesn't have a long effect. So that's why Ativan has a common use. I use it quite a bit. But I try not to use it. And the reason I try not to use it is because even though it's effective, it has a chance of tolerance, tolerability, addiction, dependence. So that's the problem, right? It works effectively, but it has some longer term effects that we have to watch out for. So I tend to try to keep it in a short run and try to keep it short. And if it can, taper off quickly.
Okay. And then there's a follow-up question, says, for how long one needs to take these medications?
That's a long question because the thing is, the short answer is indefinitely. Because in the first slide I showed you, bipolar illness doesn't come and go. Episodes come and go, but the illness itself comes and goes. And so the target is to stabilize mood and prevent new episodes. So for each episode might last for depression 3 to 6 months. Oh, hey, doggy. It might last 3 to 6 months, which means that for that episode, you might want to treat for at least 3 to 6 months for that episode, right? And so when people ask me, what's the shortest I need to be treated? I'd say at least 6 months and maybe a year, because I want to add a little bit, right? But usually my real answer is like, yeah, I'd like you to go a little bit longer, right? Because I want you to prevent a new episode, right? I want you to prevent episodes. The last point about that I would say is this, just to sort of put those two pieces together, the short and the long, right? I don't take these medications with you, so I don't know the side effects. And I can't tell you how you can tolerate the side effects, or you got to deal with it. I can't say that, right? So the middle ground is that when you have an episode, you should take it for at least the period of the episode. And then you should take it for the period that's the highest risk of relapse. So if one has an episode today, tomorrow, your chance of having another, not an episode, but having a lot of symptoms is 100% if you have an episode today. In a week, it's probably 99%, right? In 3 months, it's probably like 80%. In 6 months, it's probably like 50%. In a year, it's probably like 20, 25%. So that's pretty high. So I usually say, even if you don't want to be on the medication past a year, you want to decrease the probability. So maybe you want to wait for a year, year and a half, 2 years, that range. If you really want to come off, then let's come off in a slow fashion. So rather than saying how long to be on it, I'd say, when can we come off in a safe, calculated way?
Perfect. Thank you. Thank you for answering that in detail. The other question is, can you elaborate more on the dosage in the drug and how Stanford is driving acute monitoring measures and prescribing?
Is there a specific drug they want to talk about? So usually the way we think about a medication, okay? So each of these medications, when they have a study, they usually have a mean or an average dose, right? So now I have students and I see people from the community, for instance, so patients from other psychiatrists in the community. And oftentimes they come up with these funny doses, right? Because they want to maximize tolerability or something like that. And what I tell my students is like, if it's really tolerable but it doesn't work, it doesn't mean anything, right? If it's really intolerable and it doesn't work, it doesn't mean anything either, right? If it's tolerable, I mean, it has some side effects, but it's effective, then we got to tune it up, right? So the key of all that is that it has to work. And so what I tell people is like, let's get to a dose that works. And that dose that works is based on the studies, right? So for instance, I'll just name off a few. Depakote, the dose is based on your weight. So it's usually a target dose of about 10 times your weight in pounds. So if somebody's 150 pounds, the average dose is 1,500 milligrams. Okay. The average dose of Lamictal is 200 milligrams. The average dose of Zyprexa is 15 milligrams. The average dose of Abilify is 30 milligrams. So it goes down, right? I can give you the average dose of each one of those, but it really depends. Now, once you get to that dose, if you can't tolerate it, let's come down, right? If you, I know you can't tolerate, at least I kind of give you something a little bit less you can tolerate, and maybe it can be beneficial. But what I don't want to do is give you half the dose and it doesn't work, and then you go somewhere else because you're depressed or something like that. So that's how the dose is determined. I think there's a second part to it. I forgot what it was. Sorry. I'll write down some of the questions. Oh.
Let me go.
Yeah.
Okay. How Stanford is driving acute monitoring, measuring, and prescribing. Yeah.
So I assume that the question for that is like looking at evidence-based and measurement-based practice. So most of these studies, what happens is that we don't just have people come in and they say they're depressed or they're manic, and we just, okay, fine, you're manic, we'll give you some anti-manic drugs. What we do is we do a scale. So we measure the symptoms of mania. For instance, like how euphoric are they? How many hours are they sleeping? If they're sleeping less, are they energetic during the day? Are their thoughts going fast? Are they having talking fast? Are they doing risky things? So we count those symptoms, look at those symptoms, look at the severity. And if they have enough symptoms, they say they're manic, then we treat that. Now, sometimes people say they're depressed, and you count the symptoms of depression, and then you screen their symptoms for mania, and they actually look like they're mixed. So then if that person, we might treat for that. So we look at the symptoms, have a measurement of that, and then we decide on the best course of treatment. So if they have mania, we might give them anti-manic drug, we may add it in. And then next time they come in, we screen them again for symptoms and then adjust the dose based on that, side effects and benefit. Now, the reason that's beneficial is this, right? When you ask somebody that's suffering how they're feeling, it's usually good or bad. Okay, it's not usually, I feel 10% better. It's usually like that, right? And it's actually not good or bad. It's usually some gradation of that. It may be like on a scale of 1 to 10, where it's like, it's really not a scale of 1 to 10. It's usually a scale of 1 to 4. I'm about the same. I'm a lot better. I'm a little bit better. I'm a lot worse. Something like that. Some kind of measure like that. So what I tell what students is like, if you give a patient a scale from 1 to 10, if they're 10, they're going to say they're 10. If they're 9, they're going to say a 10. If they're an 8, they're going to say a 10. If they're a 7, they're going to say a 10. And if they're a 6, they might say they're a 6. And the reason is because when they're a 7, 8, 9, or 10, they're spending all their effort trying to hold it together. And it's just terrible. It's just hard. So the severity may feel the same, but maybe at a 10, they're not getting out of bed. They're not going anywhere. Whereas a 7, they're really struggling, and maybe they go out a little bit. They don't enjoy it, but they go out a little bit. So for them, it's just a struggle. But for us, if we want to gauge the benefit of the medication, that's where all those little points come in. Like maybe they're sleeping a little bit better. They said, well, I got out and I got tired. That's how we keep track of the treatment in the acute phase, and then the dosing and the side effects. We also screen the side effects.
Wow, thank you. Okay, the next question is, you briefly mentioned TMS.
Yes.
Are there any recent studies regarding TMS and depression? If so, what is the current thought regarding its use with depression? Are there any concerns regarding long-term side effects?
That's a really good question. So TMS is really new, transcranial magnetic stimulation. And just get everybody on the same page, what it does is it puts a strong magnet on your skull, and that magnet goes deep enough that creates a magnetic field. And for those physics students of yours, the magnetic field creates an electrical current. So it causes an electrical current in the brain, very small. Okay. So because the magnetic field turns on and off, on and off, on and off, and that causes electrical current. And really, our brain is just a bunch of electricity going around. Okay. And so when you do that, you can turn on or off certain parts of the brain. That's the whole basic idea. Whereas ECT turns on a whole parts of the brain, but this one targets specific areas. That's the whole point of TMS. TMS is shown to be effective for depression, unipolar depression. Okay. It's FDA approved for unipolar depression. It is not, and is excluded for bipolar depression because it wasn't studied for that. It's not that it's not effective for bipolar depression. It wasn't studied for bipolar depression. Now, there's early studies that shows that it's effective for bipolar depression. But the reason FDA hasn't proved it yet is because you don't do it right, people get manic, right? So this is a really biological illness, right? If you hit the right place, you get depressed. I mean, you get depression better, but if you hit the wrong place, you get manic. And interestingly, if you go to the other side, it helps the mania. Now, this is really preliminary information. So like this is not fully published. So this is new, but this is where we're going, right? And that makes sense because TMS is hurt in certain parts of the brain that we think are involved in these processes, right? When I used to do research, Ravinna said like I used to do brain imaging, right? So I didn't do TMS research because it was a long time. I did it a long time ago. What we found was like these parts of the brain are involved. But unfortunately, we can't hit those parts of the brain because you have to open up somebody's skull. That's no fun, right? So TMS is really good. You induce this current. You don't break the skull. You get a little tapping in your head. You get a headache sometimes. But other than that, the side effects are pretty good. Occasionally, there's risk of seizure, but that risk is really, really low, right? But you talk about it. It's really the headaches, okay? Yeah. And for bipolar patients, it's the risk of this mania.
Mania.
That's where we are right now with the state. It probably does help with bipolar depression. We've got to figure out the dosing. We got to know the side. And what happens when they're manic, we got to jump to the other side. And that timing is what we have to tease out.
And I understand that TMS is helpful for OCD as well.
Yeah. So I want people to think of these illnesses as brain illnesses. Okay. So OCD, many, many years ago, when you had somebody that didn't respond to any medications, they did brain surgery. Okay. And that part of the brain surgery is in this part, like right over here in the middle. Okay. And they go in there and just cut that area. That's not a good thing, but if people that had really bad OCD, they went and did it, right? And this TMS hits that area. Isn't that a coincidence? It's not because it's just sort of random. They hit that area, but no cutting, no nothing, and that helps OCD. Now, OCD is a very difficult thing to treat, and so that's really helpful. If they find it's helpful for anxiety, maybe it can be helpful for some levels of cognition. So the idea is that not that TMS helps these things, but yeah, TMS, it's a magnet, turns on and off, causes electric current, and if you just want to turn on a certain part of the brain, maybe that's what gets it. And in fact, if you turn on the on and off signal faster or slower, it actually turns parts of the brain off, right? So you can turn it on, you can turn it off. So I think in the next few years, there's a lot of research in looking at these things, pain syndromes, OCD, anxiety. These are all being studied right now. PTSD, these are all being studied.
Perfect. Thank you so much. Okay, so that was done. The next question is, I have suicidal ideation for 30 years. I have bipolar. What would you recommend, please?
Well, that suicide ideations is multifaceted. And I'm sorry, it's really troubling to hear that because feels kind of alone when you have that. It's oftentimes unfortunately common in bipolar, and people with bipolar have about 50% of bipolar patients have had suicide ideations at some point, and at least 15% succumb to suicide. Okay. And I've had my own patients do that. So that's really tough. Obviously, treating depression is important. Being aggressive about treating the depression is important. And there's a few medications that are actually really effective for suicide ideations separately. So those things include lithium and clozapine. I didn't put that on the list. Lithium and clozapine are two things that are separately shown to be effective for suicidal ideations and gestures. So I would recommend, if that's a chronic issue, to consider thinking about one of those agents if the other things haven't been effective. But really treating the depression being, sometimes I see this. If somebody has these symptoms chronically, it kind of gets downgraded in the clinician's thinking, right? And it's important to sort of, if you can't bring it up because you've had it for so long, is to have somebody in your life bring it up and sort of point out, this is not just chronic, but it's an issue all the time. It's an issue, right? We need to address it. Okay, advocate.
Thank you for answering that. So the next question seems like it's a follow-up question from the earlier questions about medications. And so it just, the question only mentions that, so is it used as a daily medication or as needed?
Ativan probably, right?
Yeah.
That sounds like a Ativan question. So I prefer Ativan to be used as needed, because the main problem I said with Ativan is that people who develop tolerance is a benzodiazepine. It's like alcohol. It affects the same part of the brain as alcohol, right? It's a little bit more controlled because you have to get a prescription, so you can't just go and buy it. It has smoother offset. It doesn't cause liver damage. Okay, so those are benefits, right? But still, it's like cause dependent like alcohol. So the reason people get addicted to those things is because it's on and then it's off. And that sudden shift, no good, right? That's one bad thing, right? The other thing is that if it's always on, it causes your receptors, the parts of the brain, to sort of shift, the change. And that's what tolerance is. So if you leave it on every day, then you develop tolerance, you change. It's like if I keep hitting you in the arm, that's going to get calloused and numb. You don't want that, right? Mm-hmm. So if you're going to take it, then I would say infrequently and for a short time, because then it wears out and your body resets. Your body doesn't have a long reset, right? So that's what I would recommend.
Thanks. The next question is, my son, age 23, is diagnosed with bipolar. Recently, it started with a high mania and was treated with antipsychotics, but I'm noticing he's really quiet. He's still very slow, and I'm wondering if that's a side effect of lithium, which he's taking regularly.
Okay, so that was a complicated question because somebody said antipsychotic and also lithium. Okay, so there's a couple of things that happen after mania. One is that there's a propensity to become depressed. So we want to see if quiet doesn't mean depressed. That's the first thing. That's the most common thing. Number two that happens is that you need a lot of medications when somebody's manic. Like somebody may be able to suck up 6 milligrams of Ativan when they're manic, sometimes 8. But when they're depressed, they can't take any because it's just too sedating and they're already depressed, right? So when they're not manic, whatever they need, whatever the hospital needed or the clinician needed to bring down the mania, it's too much when they're not manic. So that could be a side effect of medication. So this disparity between, is it depression or is it a side effect, is a big problem. It's the biggest problem I have after mania because I'm an outpatient, right? So that's the biggest problem I have. And the way to figure that out is because sometimes you can't tell, right? You think you know, but you don't really know. Is, as I said, you try to go through all the symptoms. How many hours are you sleeping? What time do you wake up? Are you feeling sad? Are you enjoying things? There's your concentration. Are you distracted? All those symptoms, you count them all up, and then you get a better sense of where it is. Because if somebody comes in and says, well, I'm not really that depressed, but they're sleeping 12 hours. Well, maybe it's a side effect of the medication, right?
Thank you. Are there any alternatives to lithium?
All those other things I listed as an alternative lithium. So lithium is a prototypical mood stabilizer because it's the first one that came out. Just a little backdrop. Okay, so after this Dr. Cade, this Australian guy, came up with lithium, it kind of didn't do anything for decades. Okay, and at that point, we didn't really have a lot of medication options or treatment options at all. And so it happened that a lot of people ended up in institutions. Okay, and they just stayed there for a long time. Okay. It turned out that when they started, there's a psychiatrist that noticed some of these people in these institutions and noticed that some of the patients were getting better at times, and they left the institutions for years, and then came back. They came in and out. And other people, they went in when they were 20 and they never left. So they just kind of stayed there. So he differentiated these two groups as some people having more, something became schizophrenia, another group calling them manic depressive illness or bipolar. And in those bipolar patients, those patients started becoming treated with lithium. They said, well, maybe it's this sort of cyclicity, and they gave lithium. And what happened when they gave lithium is the hospitals became half full because the patients with bipolar didn't have to stay anymore. So lithium is very important, but it has problems with the kidneys and the thyroid and tremors and sleepiness and go to the bathroom a lot, drinking a lot of water. So it has a lot of nuisance side effects and other side effects. So that's why there's all these other agents: Depakote, Tegretol, Zyprexa, Seroquel. All these things are alternatives to lithium, and some of them are better because of mixed symptoms or depression. So it really depends on the specific case for the person, but they're all effectively good.
So another question for lithium is that why in your presentation is lithium by itself in the class of medication as compared to others?
Yeah, that's just because it doesn't fit into class. It's just it's a salt, and they haven't actually found any other salts that are effective. Okay,
I see.
So that's why it's in a class by itself. All the other medications are in a certain type of medication, like anticonvulsants or antipsychotics. And if you think about the way medications are developed, basically what happens is drug companies are not that creative. They want to make money. And so what happens if they find a medication that works, then they start making all the medications that look like it. They just make them a bunch. So Zyprexa, for instance, Depakote, okay? They found Depakote works, and so they started making Tegretol, and they all kind of look the same, right? They started making a bunch of these, and they test them all. Some of them work, some of them don't work, right? What happened with, like, for instance, the antipsychotics is that there was a medication called Clozaril. That was a long time ago. It was pretty effective, but people couldn't stand it because it had a lot of side effects. So it sort of disappeared, and then it came back. And because it was very effective, they started making medications like it. So lithium is by itself because there's nothing like it.
Okay, so the other question is for someone who has both bipolar and ADHD, is Strattera safe to take without worrying about it triggering bipolar? No.
The short answer is no. So this is a question I've had for consistently for the last few months. I don't know why that is, but it's a common problem, which is bipolar and ADHD. Okay, and when they occur together, it becomes a problem because the ADHD medications can oftentimes destabilize and cause mania. The most common ones that cause mania are like the stimulants, like Adderall, because Adderall is basically amphetamine. And then the next one would be like maybe Strattera and modafinil and Wellbutrin. Those are all effective for ADHD, and they have some risk of causing mood instability. So that becomes a problem because we have to stabilize mood. And if we still have ADHD symptoms, then we might have to address that. But be careful.
Are there any dietary restrictions and supplements not to have while on medication?
Not necessarily on these medications, but some antidepressants like the monoamine oxidase inhibitors, you have to have a special diet. Now, I would say almost all the medications listed, pretty much all of them, there's a handful of them that are not, but almost all of them have some degree of weight gain, some mild, some severe, and some incapacitating, right? So I would say that, and one more thing, I've become an expert in like weight gain and obesity in the American population. And it's a big problem, not only in the American population, but particularly in patients with mental illness and on these medications. So I would say that it's really important for most people to really pay attention to their exercise, their diet, not only because it's good for your mental health, but it's also because if you're on these medications, there's a risk of weight gain on these medications and diabetes.
That's great. The next question is, how far are we in determining one has this disorder using blood tests rather than history?
We're not far. Unfortunately, we're not far. 20 years ago, when I was doing brain imaging, somebody asked me the same question. I said, maybe 5 years. 5 years later, I said 5 years. Now I say 10, 15, 20, I don't know. Nobody really knows because as when I was doing brain imaging, we thought, oh, that'd be pretty good. And we know. It turns out that it's too complex. we know the parts of the brain that are involved in emotions and mood. And people with bipolar, that part is disturbed, but it's not specific to bipolar, right? So we know the pathways that are involved in mood, but we don't know the cause. That's the problem. And then we know genetics. So, 15 years ago, we had populations of people where we go, oh, wow, these people, 100 some people, they have this gene that's a problem. So we know the gene. Then we go to another population, that gene doesn't exist. They have a different gene. And so what happens is we find that there's some genes that, have a high risk, but that gene is low probability in the population. So it happens in that group, but not in another group. So what we're finding is that we're finding more about the biology more than actually real risk factors that are applicable for other people. Okay. But as we learn more and more and more, this field of brain imaging is fitting in with the genes and it's fitting in with brain circuits. Okay, so hopefully that all fits together. TMS is one of those examples.
My daughter takes Lamictal and is stable now. Since Lamictal is under anticonvulsant, can she stop taking Lamictal and only stay on Geodon? I don't know if I'm pronouncing it correctly.
Yes, Geodon's correct.
What would you recommend as the least weight gaining med?
Wow, so somebody that is stable on lamotrigine, first of all, if somebody's stable on something, then I would try to stay on it unless they have a side effect. If they have a side effect like weight gain, that becomes an issue because weight gain is pretty common. Yeah. So the two, there's two medications. And those two medications this person mentioned are the two that have the least weight gain. Okay, so lamotrigine is basically a little bit weight loss, but it wasn't statistically significant, so it's basically neutral. Okay, and Geodon, I actually did a study on Geodon for weight loss, and people actually lost weight on Geodon. So I wouldn't say they lost weight like it's a weight loss thing, but it was at least on the negative side. So if you had to choose between those two, without knowing the history at all, I would say out of those two, because lamotrigine is pretty neutral, and the atypical antipsychotics where Geodon is tend to be positive, I would probably choose Geodon out of those two. Lamotrigine out of those two, sorry.
Okay. The next question is, could you share an inspiring patient story to give us some hope?
Yeah, let me think about a composite patient. That way it does, people don't go, oh, I know that person. Okay, like that. Okay. Because I work at Stanford, I have a lot of students. Okay. And it's pretty rough when your life is going great. You're getting to Stanford, everything looks perfect. Everything is perfect in your life. And then the age of onset of a lot of these mental illnesses is like early 20s, right? And so they get a manic episode. I had a patient once who was about to come into Stanford. He already got accepted. He's about to come in, took a summer break, got manic. Okay, got manic. And he didn't think he was going to start. In fact, he got really manic. He was actually not even here. He was somewhere else, but he knew Stanford had a good program and he's going to come to Stanford. He flew over here with the help of nurses and a lot of support on the plane. That was a big deal. So he is really in bad shape. He really wanted to start Stanford. This person really wanted to start Stanford. And he was delayed. He was afraid he wasn't going to start. But it took a while. And eventually he took a couple classes. And then he took a few more classes. And he's like, man, I don't think I'm going to make it. And so I think he might graduate like in 6 instead of 6 or 7 years, something like that. But, he stayed well. He got some depression in between. And he got, oh, no. But he stayed in there. He made it through. And that's what happens with people with bipolar. They have a bad episode. They struggle for a while getting, a hang of it. And he made it through. And then he did okay. He ended up getting a master's degree. He ended up getting a nice job. He then became an executive. He ended up getting nice stock options. And he became one of the rich people. He did very well. Now we don't hear about him anymore because he moved away and did other things. But he did very well. He's probably that was probably 20 years ago. He's one of my first patients when I got to Stanford. So that guy must be like 40 something, 40, 50 years old, got a family. He's changed jobs, not because he didn't do well in jobs. So he did well, but he looked bad. And he thought his life was I remember when I saw him after being in the hospital, his first thing was like, I mean, I don't even know what the point of life is. Everything was good and everybody dies. So what's the point? And I told him back then, he said, it feels like that now, right? And you may not believe me, but it feels like that now. But when you go through life and you start doing things again, and just put your head down and just do stuff and look for the next thing and next thing, eventually you start enjoying the things that you put together. And sure enough, when he has kids, he's talking about his spouse and his job. And I mentioned the other day, he says, yeah, that's kind of funny, right? Because when you have these things, it does mean something, even though everybody dies, right? All those markers in our life, the people in our lives, NAMI and all these things, all these things play a role in our life, even when we don't think so.
Wow, that's great. Thanks for sharing that. Okay. Next question. I noticed the data and the bar charts in the earlier slides about different types of medications were from around 2006 and 2007. Do you have a view on how the distribution would be in the more recent years, particularly with the new antipsychotics?
Yeah, that's a good question. So definitely the new antipsychotics is a much more, it's a higher percentage of the prescriptions right now. And there's a couple of reasons for that. Number one, they work much faster. Okay, this is a great question. Number two, the Depakote, the lithium, the Lamictal, they work on one side. The Depakote and lithium, they work on the mania better, but they don't work for the depression that well. The Lamictal works on depression better, but it doesn't work for the mania. So a few of these new ones, they work for the mania very well, and they work for the depression very well. So they cover both, like that treatment philosophy I said. So like quetiapine, Seroquel works well for both. Vraylar works well for both. So a few of these things work well for both, and that's sort of the goal. Drug companies know that. It's like, this is what they're not all bad, right? They're trying to get to the thing that we want, right? So that's another reason that they have a broader spectrum of efficacy benefit. So like, why would you take penicillin when you can have a third generation antibiotic that covers everything, right? So that's what we're doing. We have these new agents that cover more range. They work faster, they have more range. Now, in that atypical antipsychotic category, there's like third generation now, right? I call it second generation, but it's actually third generation, because the first group, a lot of weight gain, a lot of sleepiness, that kind of thing. They work fast. The newer ones, less weight gain, less sedation, less diabetes. So they're moving towards that group. So I'm hoping that that's what we're going towards, and more depression indications. But that's where we're going. And but I think, if we're lucky, and this is the beginning, we'll have other interventions that are maybe not medications. The problem with medication, you take it, it goes everywhere in your brain, everywhere in your body. So that's where you get side effects. It's not targeted. So it'd be nice if we get more targeted treatments down the road, but we're not there yet. TMS is one option, but maybe there'll be targeted medications in the future too.
Next question, if TMS can trigger mania or mixed mania, why does ECT not?
That's a really good question, because TMS, well, I don't know for sure, but this is the reason, okay? TMS, you go to this part, it hits that part. It doesn't go anywhere, right? ECT, you put the electrodes on somebody's temples, and it goes everywhere. So there's no selectivity, right? And that's why you get memory problems, you get all sorts of headaches, you get the whole shebang, because it's indiscriminate, right? So it's what we call a dirty treatment, because it just hits everything. It's a shotgun. It hits everything. It's effective, but it hits everything. So you get a lot of side effects. But TMS is targeted.
Yeah. Okay, next question. When do the first symptoms usually appear? At what age? In childhood? Is there a genetic component?
Yes, that's a good question. So there is a genetic component. As I said before, when they look for genes, there are high risk genetic markers, but there's a lot of these, and so they are more specific to groups of people. So that's one piece of information for genes. The other thing is, if you look at twin studies, so if you look at identical twins, and whether they're raised in the same family or if you adopt them out, they have the same risk of bipolar. So if one twin has it, the other twin has about a 70% chance of having bipolar, versus fraternal twins. Like, they're still twins, they're same womb, same family, they're about 20%. So that extra 50% gene load gives them about 3 times higher risk of bipolar. So that suggests there's some genetic component to it, okay? Now, usually the age of onset of bipolar is in the late teens, early 20s. That's usually the case. If you have because it's genetic, if you have a family member with bipolar, and now you have a child, identified family member. So that means that's a little bit more severe, right? Then the child might have symptoms of bipolar that you can't tell, right? At a young age, they might have bipolar symptoms at age 12, okay, or 6. And I have patients where their kids, they go, wow, man, I think he's going to show bipolar. You can't diagnose bipolar at that age because at 6, they don't look like they're manic. No, they're like irritable or they're moody. You can't diagnose that. I mean, kids are moody sometimes, right? You can't diagnose that, but they may have other kids and go, wow, this kid's really moody, right? And, if you just have one child, you may not think anything of it, right? Because that's fine. But if they've had other kids, you go, wow, this one's, the first one's definitely moodier than the second one, right? And that continues, it gets worse and when they hit puberty, right? So that's one option. The other thing is when they're young like that, they may present oftentimes with ADHD symptoms, inattention, because they don't know what they're doing and they're moody, they have mood symptoms, but they don't know what it is. And so when that happens, they get inattention because that's where it comes out. They have to do work, they have to sit down. They can't just be themselves. So they have to sit down. There's a boundary or a rule. And so they have problems, right? So those symptoms oftentimes present first when you have a kid of something that have bipolar. The kid doesn't have bipolar yet. Okay. So those are early symptoms. You can't diagnose that, but when you can diagnose it, it's sort of like the puberty, a few years after puberty, or late teens, something like that.
Got it. Okay, so next question is, do you use SAINT treatment from Stanford for bipolar?
Yeah. So I don't do it because I don't do TMS. I'm doing meds mostly. But yeah, they do SAINT. So for other people that don't know, SAINT is, I forgot what the coding is, but it's Stanford Accelerated Intermittent Theta Burst. So basically it's like Stanford initiated. But the idea is that when you're doing, let me use an example here. Okay. When you're doing TMS, okay, you don't care about the skull. Okay, you don't, but that's all you got. So you put this magnet on somebody's skull, and what you're really aiming for is the brain underneath, right? Now, what happens is the way you know where the brain is underneath, you don't like stick a hole in there and figure out what it is. You don't do that. What you do is you go to that part of the brain, at a skull, you turn on the magnet, and you move the magnet until the thumb twitches. Mm-hmm. When you know the thumb twitches, then you know where the thumb is in the brain. And you take that and you move forward a little bit, right? It's a protocol. And you guess based on that. So you guess on where the emotion part is based on where the thumb is. Now, that's not so good, but it's what we got, right? So what people recognize is that, yeah, that's not so good, but that's all we had. So what the SAINT procedure does is they take a brain image of that and they hit the thumb and then they stimulate the brain and then take a picture of the brain, a functional picture of the brain, and they see what part of the brain is activating. Because that's really what we care about, right? And is that the part of the brain that we want? And it turns out that a lot of times we're way off on the thumb. Okay. So that thing that we're doing right now, it's close, but it's for some people, about maybe a third of people, but the other people, it doesn't work that well, right? So that SAINT procedure, what it does, it figures out the part that actually is important. Now, I've been cutting you guys short a little bit. We don't really care about the surface of the brain, right? What we really care about is the deep part of the brain in here, okay? Deep inside, behind the eyes. Because that's the part of the brain that actually controls emotions, fear, anxiety, all that stuff is in there, right? That's part of the brain I was studying before. But you can't get that part of the brain with a magnet because the magnet only goes down a centimeter. It turned out that the SAINT procedure is even better than what I said. What it does is when you hit out here, the brain is a circuit. It's not that this part just does that. If that part interacts with another part of the brain. And so this part actually is not really what we want there. That part controls the anterior cingulate, which is the deep part of the brain. And so when you hit this part, the magnet, you're seeing if the inside turns on. And now you got gold because remember we're talking about targeting? This actually is a targeting what we want, right? So all the research we had before, about this is the part we want, but we can't hit it. Now we have a way to hitting it, okay? So that's what SAINT is. And they put this cap on it. And so when you go in, they hit the same place every time. That's what it is. And, that's what we want people to do because it's much higher effective. When TMS first came out, I thought, yeah, it's not going to work because the effectiveness rate for TMS at the beginning was 20%. Terrible. And you had to wait 4 to 6 weeks to even know it's going to work. But now it's much better.
Great. Can bipolar be mistaken as epilepsy?
Repeat that question again.
Can bipolar be mistaken as epilepsy?
Oh, rare, very, very, very rarely. There are some very rare forms of epilepsy that can cause bipolar-like symptoms, like in the frontal lobe. And because what you have to have is you have to have an epileptic seizure that doesn't cause a lot of motor symptoms like this, right? Because if you have that, then they think it's epilepsy, right? You have to have an epileptic seizure where it doesn't affect that, but it affects mood, right? And there's certain frontal lobe in the front that in this front part of the brain where you can cause mood symptoms without motor symptoms, but that's pretty rare.
How common is paranoia as part of mania? And
50%. Sorry.
Sorry. How common is paranoia as a part of mania? And are certain meds better for stabilizing that?
Yeah, all the atypical antipsychotics are good for mania. Okay, and about 50% of people with mania have psychosis and paranoia. Some clinicians will say that certain antipsychotics are better than others for mania. Really what it is that some medications have better sedation, okay? Because actually from head-to-head study, they're pretty similar, okay? So some of them like Zyprexa, olanzapine, it's sedating. So it works much faster than, for instance, Geodon. Geodon's not sedating, right? So, but if you give them like long enough, they both work for paranoia. But in the hospital, most psychiatrists don't use Geodon because it takes too long. The Geodon's benefit is it doesn't cause weight gain so much. So yeah, I think from an honest answer, they're very similar, but there are a lot of psychiatrists will say like one is better than the other.
Okay, so the next question is, does Zyprexa 5 mg and 200 mg of Seroquel good for schizoaffective?
So schizoaffective disorder is basically a combination of having psychosis at times and then mood symptoms at times, and sometimes together, sometimes they're not together. Basically, you have to worry about paranoia and also have to worry about mood symptoms. So Zyprexa and Seroquel are both effective for that. And without understanding that particular case, both of those, Zyprexa and Seroquel, are at low doses. Zyprexa is 5 milligrams. The usual dose of Zyprexa goes anywhere from 2.5 to 20 to 30 milligrams. So 5 is on the lower end. Okay. An average dose of Zyprexa for somebody with bipolar is about 10 to 15 milligrams. For mania is about 20 milligrams, but for, and so that's a little bit on the low end. Seroquel is what we call a non-potent medication. So it requires a high dose to get a good effect. Its dose ranges usually from 25 to 800. So 200 is on the low end of that. Okay. So I would say, these are both, they're fine. I don't know what's going on, but typically if I just said, oh, these are good doses, I'd say, yeah, they're kind of low. And why would you be on 2 low doses instead of 1 good dose? But the reason is because oftentimes you can't tolerate one.
Yeah. Okay, so the other question is, I'm wondering if there are any food or specific diets, such as anti-inflammatory diet or lifestyle changes that can help support mood stability, or any other holistic approaches, supports. This would be for me in addition to my medication and therapy.
Yeah, that last part is really important because there have been studies looking at other augmentation strategies in addition to medications. I can't think of any that are just those augmentation strategies without medications. Medication is so important. So for instance, there's different kinds of psychotherapy, and I'll get into foods in a second, that are effective for bipolar disorder in addition to meds, like cognitive behavior therapy or family focus therapy. Or this other thing that's fairly obvious, which is interpersonal social rhythms therapy. Interpersonal means like you have to have friends and you have to talk to people in the morning. Social rhythms means you have to wake up in the morning, go to sleep at the same time, have regular food, meals, exercise. That's interpersonal social rhythms. And if you have that, it's better than just taking meds. So that's kind of obvious, but they studied it and showed that it was effective, okay? So that obvious is like, yeah, getting good sleep, having a good diet, eating 3 meals a day or 4 meals a day, having friends that you can talk to. Those are all important. And if you have it in a regular schedule, it really is important. So that's helpful. Now I'm going to add in because there's a lot of evidence for this, and there's somebody at Stanford that's looking at this, and somebody at Harvard looking at this. Some people have looked at the ketogenic diet as something effective for mood. I know it's effective for epilepsy. And so that's why it's been transferred over to mood. And so there's evidence sort of emerging for that as well. And we'll have to see how that goes.
Yeah, and just to add to that, last year I attended the NAMI California conference, and there was a presentation on how diet actually helps with mental well-being, and there was some evidence to that as well. So I believe you can also find that presentation through NAMI California for the conference that took place last year, August. Okay, so the next question, it's 8:09 right now, so we have another 20 minutes. How does the doctor feel about psychedelics?
I think psychedelics are dangerous in the community. And the reason is because it's in the New York Times. And whenever it's in the New York Times, it's a bad thing. Okay. Because what happens is the New York Times preempts thorough research. Okay. I think that it can be really informative in terms of finding other mechanisms that we can sort of target for these illnesses. Right? It really does work for some people, but it can really be a problem for other people. So that dichotomy, that difference can really give us some information about where it is. But unfortunately, because it's been in the New York Times, it's much more prevalent as like, oh, this is a really cool thing. And people ask me about it all the time. And my pat answer is this: it's not ready for primetime clinical practice, right? And I know some of the researchers that do it, and they say, yeah, it's not ready for primetime clinical practice. And unfortunately, some clinicians in the community really want to do it, but it's not, it's not really ready for prime time. I've been around long enough that know there's certain things, there's a lot of things that come around, think, oh, this is going to be awesome. And it really turns out after a while, it's not awesome. I'm not saying that about psychedelics, but it's in that stage of development right now, and it's not ready yet.
What medications are safe and recommended for someone who's pregnant?
That is a long question. Okay, so I would encourage you, if you have that question in a more acute way, like you think about getting pregnant or you are pregnant, that you might consider consulting with a women's wellness clinic at Stanford, because they specialize in that question. I'll give you the sort of short rundown of that, but they can give you the actual data, which we won't cover today. The short version of that is that there are no medications for bipolar illness that are shown to be safe. Okay. And no ones that are shown to be safe. There are some that are shown to be unsafe. There are some that are shown to be relatively unsafe, and there's some that we don't know. Okay, so lithium is unsafe because it can cause a heart defect. But the risk of that heart defect is pretty low, so it still could be used. Even though it's unsafe, it's relatively unsafe. Depakote is unsafe because it causes a neurotube defect, like cystic fibrosis. I'm not cystic fibrosis, spina bifida, where babies are born with their spinal cord open, right? That's a pretty devastating illness. And so that rate is about up to 10% of fetuses. That's really high. So that is like a no-no, right? So that's like that's a really bad thing, right? And then everything else is in between. It's like, we don't really know. But usually for mothers, I don't know means like it's a bad thing, right? Because who wants to put that risk? Out of those things, the one that has probably the best data is that it could be safe because it's been used to most people. And so even though we know it's safe, at least with a lot of people, it hasn't been shown to be not safe. That would be quetiapine or Seroquel. Okay. So when I send people to Women's Wellness Clinic, they usually say, well, you could try quetiapine, right? But for individual questions, like if you have certain specific medications, then I would sort of consider that, because that's like what I know is like a lot of evidence, like this study and that study. It's a thorough study, right? And 20 years ago, I used to know all the studies, even the little ones, but I don't need to know that as much because there's these big studies now. And women's wellness, and for this kind of issue, there's a lot of important information. There's not a lot of big studies, but there's a lot of little studies. And so sometimes it's important to know at this stage of the research, it's good to know what the little studies show.
So next question is, are there connections between bipolar and borderline disorder?
So I just gave a talk to my students about that 2 weeks ago. Bipolar disorder, borderline personality disorder. So there's a connection in terms of the symptom presentation. Well, I'm going to step back for a second. Some people think they're the same thing. I don't think so. Okay. So I'm going to give you my answer. They're not the same thing, but they have connection because some of the symptoms are similar. So people with bipolar disorder have depression and then they have mania, right? They have irritability as part of the mania sometimes. And people with borderline personality disorder, they have irritability a lot of times. And they sometimes get depressive symptoms a lot of times. And they can get depressed a lot of times too. The difference between those two is when people with borderline personality disorder get depressed, it may not last that long, right? Because they have more emotional fluctuations. They get depressed and they get irritable or high, they get depressed. So they go up and down more frequently, right? And people with bipolar, the episodes are, the moods are longer, days, weeks, months, right? Versus hours, minutes. So the symptoms can be overlapping, but they're actually, when the psychiatrist looks at them, they're actually, well, they're not the same. Okay. The other thing is people with bipolar, they may be something stressful that causes a mood episode. But the mood episode then it takes on a life of its own. With people with borderline personality disorder, the key feature is that it's the experience of life and stressors in life that bring on these emotional reactions. So it's the interaction with emotion in the environment that sort of brings on the symptoms in borderline personality disorder. So one is less environmentally affected and one is highly environmentally affected. So there's a lot of other differences as well. The treatments are different. Mood stabilizers work really well for bipolar. Okay, for borderline personality disorder. Antidepressants is not so good for bipolar. Antidepressants is really good for borderline personality disorder. So there's differences, but it's hard to tease out sometimes for clinicians too.
Next question is, are there some types of schizophrenia or schizoaffective that are candidates?
Say that again.
Are there some types of schizophrenia or schizoaffective that are candidates?
Candidates for, not sure what that means. So schizophrenia is when a person has just hallucinations, voices, or delusions, or paranoia. They have that as a primary problem. Patients with bipolar can get that, but only in the setting of being really depressed or really manic. So they don't have those symptoms on their own. Okay, that's the difference. Go ahead.
I think the question is she just posted the follow-up question: candidates for magnetic treatment.
Oh, okay. That's better. That's easy.
Okay, yeah, because I think she just posted that now. That
not
was
yet.
missing.
Not yet.
Okay.
Yeah, because we don't know if the TMS is going to exacerbate paranoia yet.
Yeah.
Psychosis yet. We don't know that yet. But we will, in the next few years. It's just I know the person who does the research, they just don't have that many hands yet. So they keep adding more hands to try to do research, but they're going to get there.
Okay. Next question. How common are auditory and visual hallucinations in bipolar disorder, specifically not during mania?
That's a good question. So auditory and visual hallucinations, by definition, cannot occur outside of mania unless they're depressed. So when patients with bipolar are stable, they shouldn't have auditory and visual hallucinations because that would be called schizoaffective disorder. Okay. Now, the difference between schizoaffective disorder and bipolar is that people with schizoaffective disorder may have a little bit more dysfunction in their life because these, obviously, because they have these symptoms on a chronic basis, whereas people with bipolar, they don't have that. So I think if somebody has those symptoms ongoing, then the treatment is a little bit different.
Bipolar symptoms are getting better as the patient gets older, usually? Is that, and the question mark?
Yes, that's a good question. So the literature shows that a patient, as I showed in that slide before, it's not that they get fewer episodes, they get more and more episodes. Episodes start overlapping a little bit more. Okay, so actually, originally what happens is if you follow patients over time, like 50 years, 40, 50 years, their episodes get worse and worse. They get more mixed episodes. They get more frequent episodes. They get more rapid cycling. They get more psychotic symptoms. They get all that stuff. It's really kind of not so good. We don't see so much of that anymore. And that's because the original data was more on a time when we didn't have that many treatments. We had lithium. And so that was hard, right? So now I think I've seen a lot of patients and people don't really progress. I think a few people do, but really a handful of people, I can count on one hand, right, that people just progress. And some of them really progress because they use substances like alcohol or other drugs. That can make things worse. But if they take treatment, really, people really do get better and they don't get worse. Eventually, they might have that original time when they're not doing so well. you may have exacerbation of that. Usually they get more and more stable over time.
Any thoughts on CBD gummies?
I don't know anything about it. I don't know anything about it, unfortunately. I used to be against that because it was uncontrolled. The problem is people don't like pharmaceuticals, but pharmaceuticals are controlled, right? There's a guideline about how to make it. When you get something, you get what you get, right? Plus or minus 10%, right? So it's pretty well controlled. And gummies and stuff like that, you don't know what you're getting, right? I mean, you think you know what you're getting, right? But I'll tell you, I knew one of my patients once used to grow that stuff and sold it to these places, right? And that person wasn't always with it, okay? Sometimes an episode and they still growing this stuff, right? So sometimes, what they say they're getting is not 100%. Now, I'm not saying for all places, but I'm just saying that when they did a study looking at these kind of more natural things, treatments, they did a study looking at something like similar called St. John's wort. This is a few years ago. St. John's wort is an antidepressant. It works for depression. And they did a study and found it was effective for depression. They also found that if you put St. John's wort out for more than 6 months, it doesn't work because it just dies off, right? And the St. John's wort you find in the store, it's been in the factory. It's been on the warehouse for at least a year, right? So that's what I'm saying. It may be what you think. It may not be what you think you get. And so that's my main thing for. But a lot of people have been taking this stuff that now I'm less negative about it, unless they have some prior bad experience.
Next question. Do you ever recommend the first psychosis programs for those with psychosis in addition to meds?
First psychosis is like the program in the county?
Yeah.
Yeah. No, yeah, I think that's great because, the biggest problem with the first episode for bipolar or schizophrenia, any of that stuff is that nobody wants to have this. And so there's a big incentive to deny, right? And in that slide I showed again, going back to the slide again, it has a lot of information. The first slide is like, the episodes get more frequent. There was a study that is done by NAMI, actually. This is many years ago. They looked at their members and asked them, when was the first time you had symptoms? And when was the first time you had next symptoms? And the average time between the first symptom and to the next symptom was 6.5 years. It took a little while, right? First time between the first treatment and the first symptoms and treatment was the second or third episode. They didn't get treatment right away. And so that education piece really maybe cuts down that progression of illness, gets treatment faster, helps preserve their function. I was talking to somebody about 2 months ago that treats psychosis. And his point was that if you see somebody with psychosis, get rid of the psychosis as fast and as aggressive as you can. Because if you don't, it can really cause a lot of damage. Not only because it causes more brain type damage, but it really affects their life, right? Because if it's affecting these people in their late teens, early 20s, that's when you're going to college. That's when you're becoming more individual, more independent. And if you really mess it up, then you're off track a little bit. And it becomes much harder. So yeah, I like these programs.
Do you believe that GeneSight test is helpful?
No. GeneSight is one of those industry programs where they look at different gene components. Now, it does tell you what it tells you. The reason I don't think it's helpful is because what it does is it looks at different gene types. So it looks at different genes, like for instance, the serotonin receptor or the dopamine receptor, these kind of different receptors. And it looks at your allele, your version of it, okay? Because there are certain versions of the gene that people have that make them like different types of metabolism. So what these genes really do is it tells mostly how your liver gets rid of or processes these medications, okay? Now, it turns out the reason I don't think it's very effective for most people is because most people, their gene type is normal. Okay, it's not abnormal. Most people, when they check it, is like normal, right? And the way they do the report is like you're slightly elevated or slightly slow, but it's really kind of normal. It's not that big difference, right? So the most common people have brought these things to me, and the most common result I see is normal. Right? There's a bunch of things, there's a bunch of information on there, but the take-home point is it's normal, right? The other point is when it's not normal, it oftentimes doesn't add to the clinical picture. So like, for instance, I have somebody comes in, it's rarely they'll bring in something and they'll say, wow, it looks like I can't take this medication, right? And I go, well, when you took the medication, you got side effects. And it shows, yeah. So it oftentimes sort of confirms something that we already clinically know. Okay. I'll give you a specific example. So there was a study from Stanford looking at gene predictors of response to Celexa. That's an antidepressant. So they found this gene was on the serotonin transporter. And they found that if you had the short version of the transporter twice, everybody has two versions of it. If you have the short version, you didn't respond to the Celexa. That's pretty good. But then the author said, yeah, that's not what we said. Okay, we didn't say that. What we really said is that if you have the short version, you don't tolerate because you have a slower metabolism of it. And so you build up this drug faster because people give a regular dose. They give you 20 milligram dose and you get too much, right? So what you really should do in those people is give them a small dose. And so that's why I don't do it, because really clinically, you might have started with slow dose anyway. So it doesn't really do anything yet. But it's like other research. Maybe down the road, it'll be really helpful. But right now, it's just more, it doesn't add anything clinically.
Okay, there's two questions about psychedelics. I know you've answered that before, but there's more questions, I think, follow-up questions. So I'm going to combine both of them together because we only have 5 minutes left. So is there data that supports psychedelics will induce mania because they're considered destabilizing? And are there psychedelic clinical trials on bipolar classified persons to help with depressive triggers like PTSD or abandonment?
That's an insightful question, because the psychedelic research is looking at the benefits at adding to psychotherapy, right? And so PTSD, abandonment, those issues are psychotherapy-based issues, and the psychedelics really have shown some benefit in boosting psychotherapy in those categories. Those studies are not in bipolar, okay? But that's where it needs to be, rather than maybe a pure antidepressant. But maybe we'll find more about that. There is a study at UCSF that I know that's looking at bipolar depression for psychedelics. So that may be something you can look up at UCSF. I know they're looking for people. So it's really in the early stages. Stanford has a study as well. So these are, but not just for bipolar though. So we're looking at these kind of things because it's useful information to look for.
What effects does marijuana use on nicotine? What effects does marijuana use and nicotine use have on bipolar disorder?
Marijuana, people use marijuana mainly because it's anxiolytic. It helps calm that anxiety, right? That's the thing. And I would, as I said before, I think I was probably more against these kind of self-administered drugs in the past, but I think a lot of people use it, and there's much more data showing that's safer. But I'm more lenient. I don't recommend these things. It's not FDA approved. It doesn't have robust studies, but it probably is safer for most people. So I don't really I'm not so negative on it, but I don't recommend it. But there are some patients with bipolar that have had psychosis on it or have psychotic symptoms. And man, I just tell them, don't even touch that, right? It's not a good, you don't want to get in psychotic and then it doesn't go away. Then you're in a whole world of problems, right? Nicotine can affect the metabolism of some of these medications. So that's good to check with your psychiatrist. And so that's a problem. A lot of times people smoke because it lowers the side effects. But it lowers side effects because it lowers the effect of the medication. So you get less drug effect, but you get less drug benefit too. And obviously the nicotine also causes, because most nicotine is smoked. So it has its own kind of smoking kind of risks as well.
So last couple of questions. What do you think about an idea that people with bipolar may have brain damages when they have more severe manic or depressive episodes?
Yeah, I think that's the case, but I wouldn't go as far as saying brain damage, right? I would say that as you have more episodes, the brain gets smaller at a faster rate than an average aging person. It's not like you just hit him in the head. It's not like that obvious. But if you measure it, yeah, they deteriorate at a faster rate than the general person of their age, right? So fewer episodes is better. But the more stress in your life is probably going to do the same thing, right? Because it's probably a stress steroid kind of thing.
Okay. And then you mentioned about family focus therapy. Where might one find that kind of a therapy?
You can't find that. Nobody wants to do that. So family-focused therapy is devised by a guy named David Miklowitz, and it's based on a concept, not of family therapy, but family-focused therapy is like having the family being supportive of the patient. Okay. Family therapy is talking about how the family can work as a unit to talk to each other. But family-focused therapy is having the family being a support. That way, for instance, the family doesn't think, oh man, just take your meds, or that you're manic. Instead of saying those kind of words, being more supportive in that way. Unfortunately, people think of family therapy and family focus are the same. So there's not everybody that really focus on family focused therapy here.
And then I just have a couple of questions about doses. And so
Yeah.
one is, what is the average dose for Wellbutrin?
So Wellbutrin has a dose between 150 to 450. Probably the average dose is probably 200 to 300 milligrams.
And then what is an average dose for Abilify? That one
Abilify,
can take without any major side effects.
yeah, probably like 10 milligrams, 10 to 15, but probably close to 10.
Perfect. Okay, it's 8:30. You have,
Wow.
I think these are the most number of questions that have been asked since I have been here at a general meeting. And I think there are some other more questions too, but I know that you had a hard stop at 8:30. But I really want to thank you for doing the presentation and answering all these questions in detail and explaining it so well. I think it was very well understood and kept us all engaged. And thank you so much for everything that you're doing. We really appreciate it, and we really appreciate for what you're doing for the community. So on behalf of NAMI Santa Clara County and everyone else who's attended, I want to thank you for coming tonight and giving us so much time.
No, thank you very much. You do a lot for us, NAMI and the support groups. Patients sometimes don't, when they come to see us, they don't really trust us that much, And so having this sort of collaboration is really helpful.
Yeah, I'm so glad that we're able to work together on this.
All right, thank you.
And thank you everyone who stayed back. We had more than, I think, 75 people who joined today. So thank you very much for coming, and we'll see you again.
Thank you. Bye-bye.
Bye, everyone. Good night. Have a good night.